This is the Psychcast by MD Edge, the official podcast of MD Edge Psychiatry, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration, with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcasts, Nick Andrews. And welcome to episode 118 of the Psychcast by MD Edge. I am Nick Andrews, and I'm joined, as I always am, by the editor-in-chief of MD Edge Psychiatry and the host of this show, Dr. Lorenzo Norris. And Dr. Norris, very interesting interview that we did a while back. That's the focus of our show this week. But I wanted to ask you how you're doing and the unofficial start of summer as we record this, and just how was your holiday weekend, and how's the family, and how are you doing mentally?
You know what, Nick? I am actually doing well, all things considered. And, you know, with this, the two particular topics of this show, capacity, if you will, capacity in the COVID era, as well as what RK is going to talk about in terms of separation and loneliness. I'm going to give maybe a little bit more of what people may not be expecting, but somewhat of a personal take in regards to it. So, but I'm doing well, brother. I'm doing well.
Good. That's what I like to hear. It's just one of those things you want to do your best to ask everyone in your life, coworkers, colleagues, etc., because, you know, as everyone said, we're all in this together. When this first happened, I kind of theorized that there's going to become a point where this is going to feel like a long run. Mm-hmm. And no, you're about 60 to 70% of the way through the worst part of the run. You can't quit and walk. You got to keep your head down and try to finish. This is the part that kind of, you know, is tough. And you can see the 4th of July benchmark in the horizon. Just 1 week. Mm-hmm. I've been telling all my friends and family, every time we make a Monday, it's going to get a little better. Every time we hit Monday on the calendar, we're that much closer.
No, I'm with you. I'm with you on that, Nick.
So the interview this week is with Dr. Bill Scheidler, and it's about a topic that is relevant in the time of COVID, but relevant always, and that's capacity and decision-making capacity. And this is an interview that you did. What do you remember about the interview, and what could the listeners look forward to?
Absolutely. First off, in this interview, we have a very, very, very relevant discussion about capacity, and particularly capacity as it relates to the COVID era. We go through, if you will, the essential elements of capacity, which I think is good. And then we actually delve into a number of capacity issues or topics related to COVID, such as if a patient actually wants to leave the hospital, if you will, and they are COVID positive, what does that mean? What that gets into a lot of things in terms of public health. What type of model are we using? Really, how do we perform capacity? I mean, not so much how we perform capacity councils in the COVID era, but it seems like everything in regards to this pandemic has really started to make us think about how we do things differently. So I think that the listeners are going to have a really good discussion with this. You're going to enjoy this. Dr. Scheidler does a very masterful job of presenting all of the elements, the sliding scale model of capacity. So people are going to like it. You're going to like it. And I'm a CL guy, so you're going to like it.
Yeah, absolutely. So you can find more information on our guest as well as the topic being discussed in the show notes, complete with links and outlines, courtesy of Dr. Jacqueline Posada. She, of course, has been doing our notes for a long time. She is also an occasional guest host on this show, so that's available wherever notes are found in your app. We are going to have more TED Med content for my trip to Boston in March. That's coming later in the summer of 2020. If you have any ideas for shows or guests or feedback, we'd love to hear from you. We just found out listeners in Austria and New Zealand, so shout out to Austria and New Zealand, and email the show, podcast@mdedge.com, or you can leave a rating or review in iTunes or Apple Podcasts, and we take those very seriously as well. Okay, so Dr. RK segment, which of course comes after the interview portion of our show, relevant inspiration and just reflections on being a clinical psychiatrist, and it's more COVID stuff from her, and that's about the separation that she has from her patients. How are your patients doing? What's their separation like from their family and friends? And then what's your separation as a clinician from your patients?
Well, you know, I think RK always with some timely stuff. And on this one, I'll probably make a point of, I listen to RK stuff, but I'm certainly going to make a point of listening to it now, because again, it's timely. So as what I'm about to say, in terms of the audience, I want to make sure that like Nick actually has no idea this is coming. And Nick always does a job of like asking me ahead of time, like, you know, how are you doing? How are you feeling? And things of that nature. And in this COVID-19 era, you know, even though people probably are aware that I'm in the hospital, I'm treating COVID patients and things of that nature. All of us, and that gets into the idea of treating folks, but at the same time being separated from them. But it does COVID hit home, but it does hit home, but it doesn't hit home in a way in which it has now. So unfortunately, I found out actually yesterday that my grandmother of 93 years old has passed away due to COVID.
Oh, wow.
COVID-19 infection.
Very sorry.
So yeah, well, thank you, Nick. Thank you. Yeah. So she lived a long and beautiful life. And I was saddened to hear about it. But at the same time, I was very fortunate and grateful that of the time that we got to spend together. But the thing where I'm linking this in with RK's talk and where I'm having a firsthand experience with this is for my father, in the separation that, you loved ones go through by not being able to be there with their loved one, or not being able to reach out, or the separation, or even just the idea of like, okay, so I never knew about COVID funeral preparations, but I do now. Right. And just in terms of all of this separation and what that does to you, what that does to your patients, what that does to your family members. So I might speak about that a little bit later down the road when it's a little bit less acute. But the point is that this topics of COVID capacity, as well as how we deal with separation and loneliness. I mean, I certainly think that they're timely. I certainly think that they're things that we can think about. And I can tell you, as somebody who's been on the front lines, I can absolutely tell you that it's one thing to be on the front lines, but it's another when you actually lose someone that you love or you care about due to this. So I agree with you, Nick. We have to be prepared for the marathon. We're going to go through times like this, but I meant every word that I said. I am happy and of good spirit, and and it's a lot of that is working with people that I enjoy working with you, Gina, Jeff, and everybody, and all the MD Edge listeners and the audience out there. So yeah, just wanted to put that out there.
Yeah, I appreciate that, and I of course appreciate working with you as well. And I'm sorry for your loss and your family's loss. It's something that a lot of people are having to go through. Yeah. Making arrangements from a distance and a bunch of other very challenging things that are going on. We know that this specialty is going to be dealing with the fallout of COVID for a long, long time, well beyond 2020. So we'll be there to have these kind of conversations. So coming up right after this, our interview about separation, or Dr. RK is about separation. We've got an interview about decision-making capacity coming up right after this. Dr. Norris, thanks so much for hanging out with me again.
All right. Always, Nick. Always.
Okay, cool.
So my name is Bill Scheidler. I'm an assistant clinical professor at the University of North Carolina in Chapel Hill. I'm the associate training director for the CL fellowship over at UNC, and also one of the lead consultants at our Hillsborough campus, which is a community hospital associated with the university.
This is Dr. Lorenzo Norris, editor-in-chief of MD Edge Psychiatry. I'm pleased to speak with you today with Dr. Bill Scheidler in regards to a topic that's likely going to come up on a lot of people's radar, and that is capacity. Dr. Scheidler is going to talk with us about capacity and give us, if you will, some broad overviews or refresher points in terms of exactly what capacity is, what are the four, if you will, broad standards of capacity. And then we're actually going to get into maybe a couple of tough or interesting case examples, particularly as they relate to the COVID-19 environment that some folks might be encountering. But certainly, even though it's COVID-19, it will equally apply to, if you will, multiple other situations. So with that being said, please, everybody, stay tuned and listen to this capacity Psychcast. So Dr. Scheidler, sir, please, welcome to the Psychcast.
Dr. Norris, thanks for having me. Excited to be here.
All right. So this is something that I've absolutely been thinking about quite some time. I've been in the hospital now, probably 3 or 2 out of the past 4 weeks, or 3 out of the past 4 weeks. And in general, for listeners of the Psychcast know that I'm a CL trained psychosomatic medicine, but now a CL again, CL trained psychiatrist. So capacity is near and dear to my heart. But with that being said, I still find that the concepts or many of the things that we talk about when we're thinking about capacity are not really understood, because to be perfectly frank, unless you do it day in and day out, it's real easy to kind of get tripped up on it. So Dr. Scheidler, if you could, please, can you walk us through, if you will, some of the basic elements that clinicians need to be thinking about in terms of definitions when we're talking about capacity?
Absolutely. And Dr. Norris, I think the definitions there are really important because it's easy to mix them up. And many people will use the same terms interchangeably.
Yes.
And that adds to further complication and further confusion. And if this isn't something that you do every day, which many of our CL colleagues, this is bread and butter,
Right.
But it's easy to get that confused. And it's different in the medical hospital versus in the psychiatric hospital. So in this talk, I'll be kind of focusing more on what happens in the medical hospital than in the psychiatric hospital. But the first, I think, important term to become familiar with is that of informed consent, which seems very simple. But again, it's a little more nuanced, and a good understanding of what a good informed consent is can really lead to a better understanding of capacity and competency. So informed consent really became the standard of care around the 1960s, and with legislature coming in between the 1950s and 1970s, looking at providing patients with the information necessary to make a good decision about whether to proceed with medical or surgical care. And where this changed in the 50s or 70s, it wasn't like before then we were doing whatever we wanted to patients.
Right.
But at that time, it was more simple consent, where a doctor would give their recommendation, and then it was the patient's job to either assent or decline that recommendation. And along actually the lines of the civil rights movement, there became the understanding that patients needed to be more actively involved in that medical decision-making process. And so that's where informed consent as we know it today became what it is, really looking at providing patients with the necessary information to make an informed decision about whether to proceed or decline with recommended treatment. And so there are different standards based on what state you're in. So it's important to familiarize yourself with what that standard is and whether it's a reasonable provider or reasonable patient would want. But there are different standards. But basically, it's being able to have that sufficient information to make a decision and make an informed choice about whether to pursue medical treatment or not.
Okay, excellent.
And so with informed consent, it's, I think, a part of all of our practices, whether it's informed consent before prescribing an antidepressant or an antipsychotic, or even something more serious like ECT. Certainly our medical and surgical colleagues do this all the time. Informed consent is one of the, I think, most common practices and procedures that we do that we don't even think about. It comes so naturally. But there can be some dramatic consequences of informed consent. If informed consent is given when the patient is actually unable to render that opinion to themselves, it places them at risk. And if we ignore a patient that is capacitated or competent to make that decision and forego that, it's a matter of justice in terms of and kind of taking over that autonomous decision from them.
Okay. So again, we talked about informed consent. All right, this is very important. Informed consent in terms of making sure the patient actually has the proper knowledge, all right, in order to make that decision in regards to treatment. Again, we're going to inform consent and knowledge. Now, the next topic or definition, which I think is very important, which follows after informed consent, is capacity. When we speak about there's informed consent and then there's capacity, first off, when we say capacity, what do we mean? And how does that relate to informed consent?
Again, with informed consent, it's having it contingent upon having sufficient capacity. So capacity is something, and the assessment of capacity is triggered as a part of informed consent. I will say before we move on, it's important to note that within informed consent is the idea of situations where informed consent matters and when it does not. And so in emergency situations, so you have a serious trauma that rolls into the emergency room, they're not in many cases getting consent from the patient because it's an emergency situation. We don't have time to be able to safely assess. And in those cases, often the assumption is to do kind of what would be medically necessary and medically correct in those situations. So informed consent and therefore capacity do not apply in those emergency situations. Okay. But when the informed consent process is going through, individuals have to have sufficient capacity, they've been given appropriate information, and they're consenting freely without undue external influence.
Right.
And so oftentimes capacity comes into play when there are questions about a patient's ability to truly give informed consent for one reason or another. And I think we all do that implicitly when we go through the informed consent process. When we ask those questions and there are concerns, does the patient really understand what it is they're consenting or refusing? I think more often we get calls in the CL world about refusals of care when folks are not pursuing recommended treatment. But I think it's an important thing to be thinking about even when folks are assenting or consenting to recommended treatment. Does this person truly understand what it is they're signing up for?
No, absolutely. Absolutely. I mean, and two of those points that you just touched base on that I think would help people out in terms of capacity consults or things that they get called for. I tell the residents as well as our attendings and staff all the time that if it's an emergency, a true emergency, it is an exception. All right. We have to do what is medically necessary. And one of the biggest dangers that I've seen is when people delay care inappropriately, even by minutes to I won't say minutes, but I'd say hours when this is a truly emergency medical situation. And this is knowledge that all of us psychiatrists, as well as our colleagues in every field of medicine, know. The other component that you were talking about in regards to capacity is when we get those consult questions in regards to assessing capacity, we frequently will not get the consult question if the patient is consenting to care. And that gets into a separate discussion, but I always get interested when, as well as do judges, in my opinion, when we were having a patient just consent, and then once they refuse, then we call the capacity consult. So I think that always causes a really interesting dynamic. But again, in terms of informed consent, those elements of one, the patient needs the information. All right, they have to have accurate information. They have to demonstrate capacity. And then now the other definition in regards to, I think, talking about just capacity and informed consent in general is competency. Can you walk us through a bit about competency?
Absolutely. And so I think the distinction between competency and capacity is really important, and it's really easy to confuse the two. And it doesn't help that often in the law literature, those two terms are used interchangeably. And so it gets really confusing. But when I talk about competency and capacity, what I mean with competency is adjudicated competency. And what that means is a legally determined. So a judge has determined someone's decision-making capacity. And so whereas capacity is decision and time specific, adjudicated competency is far more concrete, and it can be far-reaching. It can be very specific to say this person does not have the competency to determine complex medical decisions, or it can apply to all things, medical decisions, finances. It can be quite global based on the amount of impairment that's been determined and then adjudicated by that judge. The easiest way to know if someone has been adjudicated incompetent is whether they have a guardian or not. And that goes into more really important vocabulary with all this, because I think there's a lot of easy misconceptions about, say the powers of a medical power of attorney, or a medical decision maker, and when those apply and when they don't.
I think that's an excellent, and that one word, adjudicated competency, just putting the adjudicated part in, I think for a lot of people, that would stop a lot of confusion in regards to capacity, time and situation specific determined by clinicians, and then adjudicated competency determined by a court of law, potentially far more reaching, but also could be also very narrow in scope, just depending on what it is. And a common thing about that is in regards to the guardians, having guardians. But I think that, oh my goodness, that causes so much confusion with teams, just those two terms. And I've had arguments with different attendings, but because they'll say, well, capacity is the same thing as competence. I'm like, no, it is not. It absolutely, positively is not. And I frequently find if we get reconsulted and we're asking many specific capacity questions, now it's the time that we actually need to determine whether or not guardianship and some type of ruling on the patient's competence or adjudicated competence is necessary. So I think with that in mind, again, in terms of informed consent, all right, those three, if you will, big components, if you will, of capacity, all right, knowledge, as well as, you already spoke about it, which is very important, it's got to be voluntary. I mean, you can't coerce or force someone into something, which, depending on your culture or community, is actually quite a big deal. It's quite a big deal when interacting with the medical system. So that also is a huge component of informed consent, but informed consent forms the basis of it. So now we've talked about informed consent. Let's delve a little bit deeper into capacity and the 4 basic standards, if you will, that we look at when determining capacity.
Absolutely, Dr. Norris. And before we leave competency behind, it's important to notice that for folks that all adults, unless adjudicated as incompetent, are treated as incompetent, or as treated as competent. Sorry. Okay. So, and that might be one Nick to fix up, but with that magic. But no, so it's important to notice that all adult patients who have not been adjudicated as incompetent are competent by default. So competency is the default. So unless someone has gone before the judge, they are their own decision maker. And so again, in that informed consent process, what you'll typically find is that a patient will make a decision, or the team or yourself even will have questions about whether they are truly making a good decision, or rather, and maybe not even a good decision, because I think that's an important point. And I realize it's easy to fall into that. I fell into that myself just there. Is that oftentimes the reasonableness of a decision and how much we agree with that decision really has limited bearing on the capacity of the patient to make that decision. Patients are allowed to make decisions we don't agree with. Absolutely. They are allowed to defer potentially life-saving treatment. But in those cases, that bar is maybe a little bit higher. But in this case, let's say we're going through the informed consent process and there are questions. Is this patient really able to manipulate that data? How do we assess their capacity? That's when that comes into question. And so the 4 standards that we look at, and these were set forth by Paul Appelbaum, Tom Grisso, and their group back in the kind of late 70s, 80s, and 90s. But they've been prodigious writers and have come up with lots of great stuff even today. But those 4 standards are the ability to evidence a choice. So can they make and communicate a choice? That's number 1. Number 2 is the ability to understand the decision that they face and the information that's associated with those choices, the ability to appreciate, and then the ability to reason. There are a lot of standards out there and a lot of guides on how to assess capacity, but really the 4 standards is the gold standard, because it really reflects the legal statutes and case law, scholarly reviews and commission reports. It's evidence-based, and it's comprehensive and flexible, which is what you need in this space. Because oftentimes you're taking really fluid and dynamic information and having to make a binary determination, yes or no, when it's rarely is it that simple. Because the easy cases are easy and the hard cases are hard.
Yeah, the easy cases are easy and the hard cases are hard. And I agree with you, because even though the 4 standards, and I mean, in Appelbaum, of course, the forensic man, so to speak, to say, or person rather, to put it lightly, that understanding, consistent choice, understanding risk and benefits, reasoning and appreciating the consequences of that. Even within those 4 standards, there's a lot of nuance and give and play. Like, for instance, understanding the risk and benefits, as I've come to work with, I don't know how many hundreds of evaluations. I mean, there's the baseline, if you will, textbook risk and benefits to a blood draw or a surgery or anesthesia. But I also get very interested in, I think it's appropriate, it's not just us determining the risk and benefits, it's the patient's interpretation of the risk and benefits in their particular context and life. So going back to what you said, people have a right to make, many, many different decisions, particularly if they understand it in the context of who they are in their life. And that's when I think you get into the reasoning aspect of it also. So, but to your point, the 4 standards are the standards, and they are the things that give us the flexibility, as well as, in a very, very, very changing situation. Now, we've talked about definitions of capacity. We started to talk about the 4 standards of capacity. It might be useful to just, in this capacity sitecast, to talk about some situations that could come up, particularly we'll talk about COVID-19, because that's on everybody's mind. Okay, that's on everybody's mind. All right, and we can come up with some questions here or some situations that some of our colleagues, whether in psychiatry, medicine, surgery, whomever, might be facing. And I'm gonna give you one example and we'll work through it. Okay. All right, we have a patient and the patient has been admitted to the hospital. The patient is determined to be COVID-19 positive and symptomatic, all right? And the patient wants to leave the hospital. And the team has significant concerns as to whether or not this patient is going to be able to self-isolate or quarantine. And they call a capacity consult, all right? So what do we think about that? What are some of the things, I guess, first going through our head, and we can have a dialogue back and forth, please?
Absolutely. No, I think that's a really challenging case, and one that I know our group here at North Carolina has been thinking about a whole lot, is what to do with this eventuality of the patient that wants to go. And you've got concerns about the public health risk. I think that we can really look through and try to address this using those 4 standards.
Absolutely.
Are they able to demonstrate a consistent choice about wanting to go? And oftentimes in those, quote, AMA capacity evaluations, really what we try to look at is, do they have the capacity to refuse ongoing medical care? And so we kind of flip it on its head a little bit. Not necessarily do they have capacity to go, but capacity is really medical decision based. And so that ability, do they have the right to refuse, or rather the capacity to refuse ongoing medical care? And it gets really challenging in the COVID-19 question, because oftentimes folks are able to make a consistent choice. I want to go. I want to leave the hospital. I feel fine. I feel fine enough. I want to go. Then we move on to understanding. And that's probably the most intuitive of all the 4 standards, is really getting an understanding of what's been disclosed. And it's more than just being able to parrot back what the provider says to them. And certainly, I think while the CL psychiatrists, or psychiatry in general, are often at the forefront of helping with continued patient education, it's really important that the primary medical team has had a chance to really share a lot of in-depth information about the risks and benefits. I think it gets difficult as a CL psychiatrist to feel like you're in that role of making that assessment, when really our job is not to make a judgment about what the risks and benefits are. It's taking that information from the expert, from that medical or surgical provider, to assess that risk, and then go to the patient and say, do you understand what they said? And how, and again, it's very variable based on the situation. And so you could imagine that risk and benefit for that individual patient that we talked about with COVID would be, risks of further respiratory compromise.
Absolutely.
It could be, worsening mental status. It could even be death.
Yes.
And so I think it's important not only for the patient to be able to demonstrate what those risk factors are, both for treatment and alternatives, including no treatment, but then also being able to look at what are the likelihood of those things happening. And what gets more difficult, even still, is if folks are able to pass understanding, kind of the 4 standards build on one another, is what the appreciation is. Do they actually appreciate that those risks apply to them? I don't know I'm sure you've had this situation, Dr. Norris, where patients are able to parrot back, this is what the doctor said, and it's never going to happen to me.
Right. Absolutely. I think it's when we were talking about that in that particular scenario, because we just illustrated how nuances can get, because we just I took, for example, there, to make it clear, a COVID-19 patient who is, let's say we said asymptomatic, not showing any type of signs. I agree with the idea of, if you're assessing capacity, going to the medical decision-making capacity for the person or whatnot. In terms of, do they know when to come back? Do they know the symptoms? Do they know the different types of treatment? And then you can get into, but again, that reasoning, like, how does it affect me and how does it affect others around me? The reasoning and the appreciation aspect. Will the person actually adhere to self-quarantining and follow-up? It gets a bit tougher, to say the least. Now, one thing I want to go back, because we're talking about capacity, but we'll also try to blend in some of the other elements of informed consent, but in this particular one, information, because I can't speak. So when assessing capacity, particularly in the COVID-19 era, I don't know how your group has been approaching this, but one of the challenges has been the information changes every day. So every day, I just was speaking with a senior in our hospital, and we were trying to project. You're doing some planning and trying to project out, and a month in the COVID-19 era seems like that could be a decade. It's because that's how much the knowledge is changing. Is there anything in regards to the education of patients in terms of COVID-19 that you and your group have done that further informs the capacity assessment process?
That's a great question, Dr. Norris. So I think if anything, where I often see our role, particularly in situations where there's not an immediate urgency. You talked earlier about those situations where hours can make a big difference, and that delay makes a huge difference. Yeah. If there is that time, that ability to wait a little bit, to say, hold up, and take a minute, I view our role as psychiatric consultants to be able to assist in some of the education. Okay. And so really trying to get an understanding of what the patient's understanding is. Where are they coming from? What set of information are they working with? Okay. And so providing some of that additional education can be really important. I'll say in general, it's been, and I think you'll find there's a lot of, despite the fact that there are really concrete standards that allow a lot of flexibility, I think there's a lot of disagreement. If you get, 10 psychiatrists together, you might get 9 or 10 different opinions about whether the patient is capacitated or not, particularly in these challenging situations. I know in this particular sense, the kind of allegory that we've found for our group has been what to do with the TB patient.
Yeah, exactly. You read my mind.
Mm-hmm. And so there are cases where patients, and I think this is where I see this situation with a COVID positive asymptomatic patient is really the risk is less to the patient, but more to the community. And so there are patients, and there's much more literature in the TB world, obviously, than COVID-19 because it's so new, where patients are deemed to be capacitated to make the decision to leave, and treatment is still forced upon them as a matter of public health. Mm-hmm. So they are unable to refuse despite being capacitated to their own risk. And so that's, I think, the important distinction is that, at least in the way that our group has viewed capacity, is that the risk posed to others in the community is not as well served in an individual capacity assessment. I think, and instead should be dedicated to the realm of public health. And so I know for us, what we've been advised by our group and also discussions with our legal team is that in those cases, we may need to let somebody go, even if they are planning not to follow quarantine. Mm-hmm. And even if they pose that risk, which we're better understanding every day. And instead that's a patient that you would alert the local county health department to let them know we have a known COVID positive patient who's living in the community. I know in the past for tuberculosis, at least locally, police have taken that patient into their custody to then facilitate treatment. And so I think that it depends on what state you're in. I think it depends on what institution it is as to who might force or who might help facilitate that treatment for a public health perspective.
I think that is a superb point. And to all the listeners there, Dr. Scheidler just illustrated something I think is very important in terms of using that allegory of TB, because we've encountered that here also, and we found it very useful. Even if the patient themselves has individual capacity, you have to elevate that to the level of a public health concern if you really are having some significant questions in regards to this patient's ability to self-quarantine or isolate. And in this particular case, because obviously if the patient's leaving against medical advice, there's something else going on, because you wouldn't call a capacity consult unless you felt as though the patient needed to stay here or you had some type of questions in regards to it. But I think elevating to your local health authorities is definitely appropriate, in using TB as an allegory, all right, in terms of what you would do, because we're facing complex cases and things that you're constantly going to have to adapt to. Now, with that, we did COVID-19 asymptomatic patient for more or less has capacity, let's just say. That's kind of where we're at, all right. Let's complicate the situation a little bit. COVID-19 positive patient, let's say mild symptoms, but nothing requiring hospitalization or ventilator use. And for any variety of reasons, but we'll say mental health reasons, serious mental health reasons, lacks capacity. Mm-hmm. Yeah, this time the patient lacks individual capacity. What has been your group's approach, if you've had to encounter this at this point in time, to a psychiatric patient who COVID-19 positive, mild symptoms, again, let's just say mild, who definitively lacks capacity, and by lacks capacity, the patient may be able to give a consistent choice they want to leave, but they in no shape or form understand the risk and benefits.
Absolutely. I think now that is a really challenging situation, and one that we are kind of preparing for. Thankfully, we have not had that experience of a COVID positive patient. Most of those patients have thankfully turned up negative. But we are bracing ourselves for that next step. I will say that an important caveat to that, I guess the lead into that question is again something that I think many of our surgical and medical colleagues sometimes misunderstand, is that the presence of even a severe mental health disorder does not necessitate incapacity. Mm-hmm. And so it's really important to make that assessment independent of that knowledge. Mm-hmm. Capacity really, in that sense, using those 4 standards, is a functional assessment and not based on labels. So even the fact that someone has dementia or severe and persistent mental illness does not mean, unless they've been adjudicated by a judge, to be incapacitated to make any decision. And oftentimes what our group has found traction in is seeing what the contribution is of that mental illness. And even if there's active psychosis, oftentimes our group will look to say, is the decision being influenced by the psychosis? Mm-hmm. I remember there was a case that I saw as a resident, where there was a patient with pretty significant psychosis and ongoing chronic auditory hallucinations who'd been off treatment for many years, who was consenting to a surgical procedure. Mm-hmm. And the surgeons were very, I think, rightfully concerned about his ability to consent for this treatment. But all of his complex delusions and auditory hallucinations did not bleed at all into his decision to pursue that treatment. And so it's really important to go through and see what folks can functionally demonstrate before we make a decision about their capacity. But going back to your earlier point, Dr. Norris, about we've got the COVID positive patient, they've got, say, mild to moderate symptoms. And in this case, I think it's really important to make that determination of both what the decision is, what the medical decision is that they're incapacitated to do. And in this case, most likely it's going to be that ability to leave the hospital against medical advice. And so I think next comes, well, practically, how do you keep somebody, particularly someone that's motivated to leave, out of the hospital? And that kind of crosses into the realm of kind of treatment over objection. How do you treat someone who doesn't want treatment? And for that AMA case, how do you keep someone in the hospital who doesn't want to? And so I think with that, it varies very much by your institution and your state. And so it's really important to be talking with all of this with your legal and risk management teams. They're going to have an interesting perspective that may be a little bit more conservative than you might think. But they're the lawyers after all. And but it's important that we all work together. But in that case, I know at least in the state of North Carolina, the mechanism that we have to keep patients in the hospital is that of involuntary commitment.
Correct.
And so
now, go ahead, Dr. Scheidler.
Oh, and making that determination that in that instance, they pose a danger to themselves by their inability or their lack of capacity to make sound medical decision-making, and staying in the hospital for continued treatment.
Yeah. I think that's kind of where I was going with it in terms of, because a lot of times when we make a capacity assessment, the questions, sometimes the capacity will be obvious one way or another, but the real question or a follow-up question is, what do you do if the patient lacks capacity? And that's where everyone kind of gets stuck. And frequently, if you don't know what you're going to do, that can cause people to not want to ask the question because they don't know what they're going to do. It's like, testing for something that you don't have an answer to, so why test for it? But again, if the patient is lacking capacity, then you do have to consider all the different things that you just outlined in regards to whether, treatment over objection, whether if this capacity or lack thereof, or lack of capacity is directly due to a severe or persistent mental illness, is this a criteria for an involuntary hospitalization? Is this criteria for treatment? Because one of the things that I always think about, if a patient lacks capacity, what is the reason why the patient lacks capacity, and can we get them back to a point to where they have capacity? In certain cases, that's not going to be we're not going to be able to do that. But in other cases, maybe we can change how the information was given to the patient to allow them to better be able to manipulate it. But again, how can you actually get the patient back to a place where they can make decisions? But again, those options, if the patient lacks capacity, all right, what are you considering? Are you going to have to treat over objection? And what are your mechanisms for that in your state? Is this a patient who needs involuntary hospitalization for a psychiatric condition that could be corrected with use of psychotropic medication, as an example? Or is this a patient with some underlying condition where maybe we do need to consider some form of adjudicated competence for the long haul or something of that nature? So I think when you keep those type of situation, will you keep that in your mind in terms of, and there are many more, because I agree with you, you talk to different psychiatrists, you're going to get different answers. If my mentor and the person who trained me, who I think is the best CL psychiatrist in the world, for all I care, in my book, is Dr. Paul Appelbaum up at Yale. So I'm sure I could hear him now. Well, Norris, there's a lot of different ways to go about this right now. So, I mean, so I can't, that's my Paul Appelbaum voice. But if he was here, I'm sure he'd tell us a whole bunch of other stuff too. But I do think that it's always, we want to definitely think about where it is if the patient lacks capacity, where you're going, and also how to educate the teams in regards to the process. Please go ahead, Dr. Scheidler.
Absolutely. I couldn't agree more, Dr. Norris. I think that that's a really important decision. And oftentimes one that we ask teams or let them know when you want this capacity assessment from us, you may or may not like the answer that you get from us, because we're going to shoot it to you straight.
Right.
I think that number one, the capacity assessment can be very challenging.
Absolutely.
But then more often than not, the real question that teams are asking is, what do you do next?
Yeah. What do you do next?
Because many, I'd say in a majority of cases, teams already know if a patient is capacitated or not, however, a pretty strong inkling as to what the answer likely is. Mm-hmm. And what they're looking for is guidance as to what to do next. Mm-hmm. And that's actually an area that I think is underexplored, and one that our group has been kind of looking to investigate and try to provide more sound guidance for. And really, where our group has gone is really looking at, first, can treatment be delayed? Is there something, if someone's about to walk out the door, then perhaps keeping them in the hospital can't be delayed. And there's some things you're going to need to do to keep them in the hospital. And for us, that mechanism for police officers to say, nope, you can't leave, is IVC, even if it's the delirious patient that will never see a day on psychiatry.
Right.
That's just the mechanism that we have. And it's important to really check with your hospital system to see what that mechanism is, both at your institution and at your state.
Okay. All right. Excellent. Now, Dr. Scheidler, I'm going to switch gears here a little bit. And we're going to go a little bit off the typical capacity discussion, but it's going to be related. It's going to be related. Okay. So as a CL psychiatrist, I'm curious, what are your thoughts about social distancing as a public health intervention?
Ooh, I think that Again, I think I like the correction that happened a few weeks in to be physical distancing.
Okay.
Because it's one where certainly a lot of the data that's come out, I think it's been hard to interpret because at least here in North Carolina and in many states across the country, I think we're not yet seeing the surge that we thought we were going to see.
Right.
And in certain places like New York and Chicago and some of our larger metropolitan areas, it really has been pretty horrible. And definitely our thoughts are with folks who are out there. I think with social distancing, it gets really challenging, or with physical distancing is not only the practical implications of that and how we provide care to patients still through this era, but then how do we help with the connectedness or not that patients and their families are feeling through all this as a result of social distancing. It's one that I think that there is going to be soon a surge of mental health needs.
I agree.
As a direct result of the quarantine and social distancing that are happening.
I would agree. Now, here's a little bit of a tough question, and we may need to, depending on how this question gets answered, we may need to edit it out. But here's a question. Yeah. With social distancing or physical distancing, if there are formal stay-at-home orders in place, can actually the public actually give informed consent because it's not actually voluntary, it's an order?
Ooh, that's a really interesting. You mean in terms of can they give informed consent about being able to go home, or
informed consent about if you view social distancing or physical distancing as a public health intervention to slow the transmission of COVID-19, depending on who you talk to, slow or stop, can we actually as a public give informed consent to something that we're actually being ordered to do?
Ooh, that is a really interesting question. And I think a real challenge that I think if you asked a lot of people, you get different answers. And I think it may or may not, I think you could make the argument that perhaps informed consent doesn't apply. I mean, and how do you enforce that if it is? I think at that point it becomes a legal and kind of a legal determination, and what folks determine to do, because I agree, it's different than say vaccines, which are recommended, but not our kind of legal mandate that are out there. And so it makes it a little more challenging whether to say folks can kind of opt in or opt out of social distancing and self-quarantine.
As we just talked about it now, I think we just answered the question. It goes back to the TB allegory, and maybe it might help people when they're forming capacity questions. Maybe we shouldn't be asking the question about whether or not someone, to be frank, whether or not someone can social distance or quarantine on the outside, because that's not what informed consent as we understand it or we typically use it for is used for. It's not a good question because no one can, because if it's a law, no one can voluntarily opt out of it. That becomes a matter of public health and the law, and that's a totally different system. So as you said, our lawyers and risk managers would get really interested in that, but which they would. But I mean, because that's always something like, can the person quarantine? Can the person, we're doing this for the good of everybody. But usually in medicine, we're definitely thinking about the individual and what is best for them and their own autonomy and their own decisions. So I would definitely say that, when it comes to public health, I'm not sure that the ability or whether everyone agrees with it voluntary or not, that becomes a matter of the law and legalities. And we're starting to see some of that when we have other, if you will, citizens of the country crossing borders, state borders, to go places. There's checkpoints. So I think that this is going to be very, very interesting. Now, you touched on something very, very important, very important. A lot of things very important. But that is, and we'll take it back to capacity, the actual ramifications of taking away, or not, I won't say taking away, or saying someone doesn't have capacity, because that does actually have significant effects or things of that nature. And can you comment on maybe how you continue to work with somebody who lacks decision-making capacity in one specific area, but as a psychiatrist, you still have to work with them and cooperate with them in other parts of their treatment?
No, and I think those situations can be incredibly challenging and incredibly complex, Dr. Norris. I think in large part what really helps me is, and I think it's really important to not only the determinant of capacity, but then what you do with that information is why. Why is someone failing? And what's the reason behind it? And can you intervene to restore decision-making capacity? And there are situations where it is restorable. There's situations where it's not. And they can be due to a variety of medical and psychiatric illnesses that are complicating that. But then there are also situations like advanced dementia where there's no coming back. Things could get better, but it's unlikely that capacitated individual will be coming back anytime soon to be able to participate that. And I think it creates some really sticky situations. Our group has found that really being, I think, as upfront and honest with patients as possible, and expressing that these are not things that I relish doing. Like, this is something that I'm doing as part of my, obligation of my job to protect you. And sometimes that means protecting you against yourself. Making these decisions. And I think it's also really important then, something we haven't talked about so far is the involvement of surrogate decision makers. And so just because someone has failed a capacity evaluation or been deemed to lack capacity to make a certain medical decision, it doesn't mean the team gets to do whatever they want to do. it then goes to that patient's surrogates
Surrogate.
to make that decision, which varies not significantly, but does vary state to state. And that's another thing that's really important to brush up on when you enter into these cases, is who does that fall in line to? Because many of us have, healthcare power of attorneys, or folks that have, there's legal paperwork to support who should make decisions for you. But oftentimes it's just where things fall.
Yes.
And is it the spouse? Is it the parents? Is it the children? Where do siblings fall into place? And what really gets challenging is when there's more than one and they disagree.
Right. Whoa, that's, yeah. Oh, tell me about that. Oh, but whoa.
I don't mean to, to rub up some difficult memories, because I certainly have those as well. But I think really involving the surrogates can be really helpful to help kind of coax these situations along. And they don't always end up in, sunshine and sweetness and light. But you kind of hope that they do, and you try to do your best to kind of honor the patient's wishes while at the same time ensuring that they're capacitated to do so.
Okay. All right. Very good. I agree completely with that. All right. And we definitely want to make a point of, and people should review the show notes in terms of surrogate decision makers, particularly with patients who lack capacity, either capacity to refuse or to consent, if you will. We definitely want to have surrogate decision makers as an option in addition to adjudicated competence. All right, as well in regards, as well as continued patient education. Now, we talked about surrogate decision makers just now, but I wanted to actually, and maybe we'll splice this a little bit differently, but I think it is important that we go back to just those 4 elements of capacity, because there's another important thing that we needed to touch base on, and that was the sliding scale standard of capacity. Because
absolutely,
yeah, there's a lot, and there are many different schools of thought on the sliding scale scale of capacity. But could you walk our audience through what that is? The sliding scale model?
Absolutely. So the sliding scale model of capacity is the acknowledgement that not all decisions carry the same weight.
Yeah.
And so a patient may be lack the capacity to make one decision, and at the same exact time be capacitated to make a different decision. Or to decide on something that isn't significant. And so really the sliding scale version really tries to look at what is the risk benefit of a particular decision. And so let's say for consent, consenting for a procedure with a low risk and high benefit, the bar should be relatively low. Whereas on the flip side, if you're consenting to something that is highly experimental, there are really high risks and very small potential benefits, then I think a high degree of scrutiny should go into whether or not a patient has capacity to consent to that treatment. And then you flip it on its head for treatment refusal. So if a patient is refusing something that has a high level of risk and a low level of benefit, maybe we would say that's probably a pretty good idea. And there would be less scrutiny over their ability to be capacitated to make that decision. The bar to make that decision would be a little bit lower.
Right.
Whereas someone's, refusing potentially life-saving treatment with very little risk, you better be darn sure that they are capacitated to make that decision given the consequences of that. And so while a patient, may not be capacitated to refuse a potentially life-saving surgery, they probably, or they may be capacitated to decide what they want for dinner. And they may be capacitated as well. One of the lowest bars in kind of for medical decision making is who should make medical decisions for them. So that person may not be capacitated to refuse a treatment that that the team is recommending, but they may be able to say, I want my Uncle Jeff to make that decision for me because he's always looked after me, or he'd make good decisions for me. And so it really matters what that decision is to help you set the bar for what level of choice, understanding, appreciation, and reasoning is adequate to define them as capacitated or not.
Look, I love it. That's in terms of that explanation. And for the viewers out there or our listeners, I'm gonna tell you, that was a superb explanation of sliding scale model, as well as the different levels of capacity. I mean, you can even use that when raising your kids, because I do it all the time. I do it all the time. I'm gonna walk the audience through it or whatnot. Everyone knows there's no psychcast about me like speaking about like one of my daughters. Okay, so for instance, I mean, in terms of like capacity to say no, like let's say you take your kid, all right, and they want to stay up maybe 10 or 15 minutes extra to do some homework. All right, so we know they got to have sleep, right? But staying up a little bit, low risk, high benefit of completing that homework assignment, you got capacity to consent to that. Gosh darn it, you are awesome. All right, now, other thing, speak to my daughter. Wait, you want to go on a date? It's not a group date? High risk, very, 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 very low. There's absolutely no benefit to that. You are lacking capacity. All right, I've made that decision. As your father, I'm kicking in the surrogate decision maker. No, absolutely not. Adjudicated competence. All right, there it is. So folks out there, I mean, you know, just I'm being a little bit funny with it, but I mean, but hey, it's got teeth. Trust me, you got to practice these things. If you're not a CL psychiatrist and you're not doing this every day, practice it at home with your kids. Trust me. It works out very well. So in any event, all right. So
I will say, Dr. Norris, to that, 2 points that made me think of that. I thought that was an awesome explanation, and I think one that drives us home, especially for us parents out there.
Yeah.
I think it brings up 2 points. One is the kind of relative designation and determination of risk versus benefits.
Absolutely.
Your daughter may disagree about what the risks and benefits are of that second decision.
She would. She does all the time. Yeah.
And desire does not equal capacity.
Ooh,
so just because someone really wants it doesn't mean that they are capacitated to make that. And I think those are the most challenging cases, is when a patient clearly lacks capacity or most likely lacks capacity, but boy, do they really want to leave, or they really don't want that surgery.
Right.
Or they really, you know, whatever that may be. And so I think those get really complicated, and it really befuddles a lot of our providers and a lot of our colleagues, because, well, they really, really want that, or they really, really don't want that.
Right.
And that's not what it's about.
That's not what it's about. You just hit the nail right on the head. I mean, it's amazing how capacity and parenting just like segue in this COVID-19 homeschooling environment. So yeah, indeed. So that really, really, really want and desire that. I find that younger clinicians are very susceptible to that. Or if you're not even aware of it, that's yourself as a senior clinician, you can get caught up in the desire or the want, and they really don't have the capacity. And we'll take it maybe even and kind of conclude on this, because I guarantee people are going to see this. There's going to be patients that, for whatever reason, we see this all the time, particularly in the COVID-19 era, we might see more of it, that want to leave the hospital to either attend something or do something. And there's a very legitimate reason why we need to keep you in the hospital. If you stay in the hospital, we don't have treatments, but we do have supportive care. They could definitely improve. And if you leave, there's going to be problems, but they're going to really, really want to go, or they're going to really, really want to do this. And that's when you have to say, you acknowledge a desire, but we still have to apply the standards here. We still have to think about this from a medical perspective. So I really like what you just said, to say the least. So Dr. Scheidler, you've run the gambit. We talked about everything. Talked about capacity. We talked about like parenting. We talked about the 4 standards. We talked about the definitions. We talked about some challenging cases. We even got the medical and legal risk team involved in it. So that's good stuff. So, but the final words are yours. Is there anything in regards to this era that we're practicing in all sincerity, that you want our listeners to hear or to be mindful of from your purview as a CL psychiatrist, as well as someone who trains the next generation of health professionals in terms of CL psychiatry?
Absolutely. No, I think first off, Dr. Norris, I really appreciate you having me on the show. It was really, really a big fan of the program, and honored to be here. But I think for all of you listeners out there, in terms of where we are right now, I think it's not underestimating the strain that this has, not only on our patients, but on our medical and surgical colleagues and ourselves. And so being mindful of the strain that this puts everyone under, and to check in with yourself when you're making these decisions and when you're making these determinations, and working not only with patients, but our colleagues in other specialties, heck, even our own specialty.
Absolutely.
So what they may be going through, and what may be informing the decisions that they are making, and taking that into account, using that as data,
Yes.
whether to inform your empathy, whether to inform your appreciation, but also to then be able to reflect on how that might be affecting you in your decision making during all of this. And so I think if I can give any word of advice, is just to be mindful that this is unprecedented times, and that we all respond differently. And that includes kind of our medical and surgical colleagues, where we interface the most with these really complicated capacity situations, and where sometimes what may seem like the easiest thing of just letting somebody go may not be the right thing to do.
All right. Well said. Great last words. All right. I want to thank you for appearing on the Psychcast with Dr. Scheidler.
Hey, my absolute pleasure, Dr. Norris. Thank you for having me. Love the show.
And that's a wrap on the interview portion of our show this week. Don't forget, you can find more information, including links and an outline to the topics discussed in the interview, in our show notes, wherever notes are found in your app, courtesy of Dr. Jacqueline Posada. Okay, it's time now for Dr. RK and a conversation on separation.
Thank you, Nick, as always, for the introduction. So we've all heard of the Kubler-Ross stages of death and dying: denial, anger, bargaining, depression, and acceptance. I think there should be a Dr. RK stages of quarantine: understanding, acceptance, reluctant acceptance, radical acceptance, and you better be done because I'm done. Not only have our patients had an interesting period of growth, but so have we. I've spoken about our exponential explosion into telemedicine and our rapid adaptation into this medium. And we've done an excellent job really synthesizing this. Necessity is the mother of invention, and we humans are adaptive creatures. But there's really an interesting sociological phenomenon going on here. We will be compliant if we feel there's a need, and when we first encountered this devastating virus, we were united in fear and uncertainty and looking for guidance, even horribly conflicting guidance. But now we've become a more discerning audience. We are not so fear-driven, and we have more data. So where radical acceptance was indeed a necessary survival skill, we have developed to a point where questioning is not only healthy, it's essential. People look to scientists for answers, as if there are uniform answers. Remember, the reality once was the world is flat. That wasn't a theory of the time. That was the reality of the time. Everyone knew. They knew. If you sailed to the end of the earth, you would drop off into an endless oblivion. And that's identical to some of the facts of our time now. Think about that for a second. Our job, as always, is to help our patients reality test. But to do this, our own ego functioning must be intact, and of course, we must all have an agreed upon reality. Seems simple enough, doesn't it? Right? Everybody knows particles behave like billiard balls. Well, except when they behave like waves. So good gracious, what does that have to do with, you better be done because I'm done? Well, actually, everything. Life doesn't come with a rule book. Science and scientists aren't all in agreement, and this quarantine stuff is being written as we go along. And just in case you haven't noticed, not only are our patients antsy to get out, but so are we. We have a lot of data points guiding us on how to move forward with some difficult but necessary decisions. What's more, because of these data, developmentally we are at the next step. And so I shift from a Kubler-Ross model to Erickson, and all of us must eventually learn to separate. And it's time to separate from our metaphoric big parent telling us what to do and move back into our own independent adult lives. I'm Dr. Renee Kohansky for the MD Edge Psychcast.
And that's a wrap on episode 118 of the Psychcast by MD Edge. The Psychcast is produced by the editor-in-chief of MD Edge Psychiatry, Dr. Lorenzo Norris. Dr. Norris is also the host of the Psychcast. The Psychcast is produced by MDH editors Gina Henderson and Jeff Bauer, along with MDH executive editors Kathy Scarbeck and Mary Ellen Schneider. All MDH podcasts are produced by our editor-in-chief and the editor-in-chief of Medscape, Dr. Ivan Oransky. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MDH Podcasts, Nick Andrews. You're listening to the Psychcast.